Bismillahirrahmanirrahim. Quote of the day is, no matter how you feel, get up, dress up, show up, and never give up. Assalamu alaikum. My name is Dr. Momina Zia, and I'm here to present the topic of hospital reforms under kind supervision of our supervisor, Professor Dr. Saira Afzal. The learning outline will be introduction to reforms, hospital reforms, objectives, hospital autonomy, types of hospital autonomy, steps to institutionalize autonomy, challenges and implication of hospital reforms, solutions to these challenges, and recent advances with MCQs. The learning objective will be, at the end of this discussion, participants will be able to describe hospital reforms, objectives, the types of hospital reforms, and how to implement these reforms. So firstly, we'll see what reforms are. These are sustained, purposeful, and fundamental changes to improve the efficiency, equity, and effectiveness of any system. In terms of sustained, it is a temporary effort that will not have the enduring impacts. Purposeful is the sense of emerging from a rational, planned, and evidence-based processes. Fundamental in the sense of addressing significant strategic dimensions of health system. Reforms are also considered as comprehensive change at various levels of health system. It is an amalgam of systemic, programmatic, organizational, instrumental level of reforms. At the systemic level, universalization of access to services, new financing arrangements, and the separation of stewardship and delivery functions. Reforms at the programmatic level is definition of specific service rights and predefined packages. Changes at the organizational level, introducing quality improvement strategies, provide choice, and provider payment mechanisms. At the instrumental level, more reliance on research, evaluation, and monitoring mechanisms, incentives for human resources, and technology development. Now we'll see the types of reforms. There are two types of reforms, big reforms and little reforms. Big reforms, they involve at least two of the following: financing, payment, organization, regulation, and consumer behavior in programs that affect a substantial part of healthcare system. Moving on to little reforms, these are the reforms that addresses only one of the Chaw's control knobs, or reforms that target only one part of healthcare system, for example, hospitals. One part of population, rural, urban, formal sector employees, or one type of service, like immunization or deliveries. So we will be mostly discussing these little reforms in terms of hospitals. Moving on to the objectives of reforms, the objective of hospital reforms, it should be to make hospitals efficient and sustainable, include redefining the governance structure, enhancing financial independence, and empowering management to make decisions without needing the constant oversight from superior authorities. It will still be providing safety nets for poor and the disadvantaged. So what kind of hospital reforms are there? We'll see. Number one is granting autonomy. Number two is decentralizing hospital management. Number three is developing an efficient management structure for hospitals. Number four is cost sharing financial arrangements. And number five is building incentive structure for staff, which will all contribute towards the hospital restructuring, consequently leading to investing in institutional strengthening and enhancing accountability. So what hospital autonomy means is that it refers to reforms that decentralize authority to varying degrees to the health facility level for a variety of financial and managerial decisions. Aim of hospital autonomy is, number one, improving the overall pattern of resource allocation within the country's health system, and number two, the performance of public hospitals. So autonomy has to be granted in functions of management, and number two, financing. Moving on to hospital autonomy, managerial autonomy. So a key feature of autonomous hospital is formation of hospital boards. For the effective functioning, the roles, composition, powers, accountabilities, and duties of hospital boards have to be defined. Now, the role of government is very important. So the departments of health, they should provide a framework for service delivery targets, norms, and procedures for giving subsidies to hospitals. Government usually gives an en bloc grant to hospitals according to the cost per bed budget allocation criteria without any regard to hospital efficiency. So these criteria that do not promote hospitals to be more efficient and need to be revised. Progress in achieving outcomes should be the criteria for resource allocation, as this would provide incentives to hospital to be resource efficient. Moving on to financial autonomy, promoting alternative models for revenue generation and introducing user fee, which can make hospitals more sustainable. Health insurance-based reimbursements, channeling funds from external sources, developing corporate contracts to provide care, non-medical revenue programs like parking fee, cafeteria, training fee, and research, etc. So opportunities for cost containment should be explored. Decrease in drug theft and supervision of purchases and distribution of items. Moving on to the steps to institutionalize autonomy in any hospital includes formation of policies for personnel management, formation of organizational development, patient safety policy, and budgeting and finances and procurement policies. So now we're going to go through the examples that will show some successful public reforms in hospitals. Number one is Punjab Institute of Cardiology, which granted autonomy under the Punjab Medical and Health Institute Ordinance of 1998. Then Sindh Institute of Urology and Transplant, managed by a hospital management board. Then moving on to Medical Teaching Institution Acts in 2015. So this initiative by Khyber Pakhtunkhwa government has given autonomy to the top government-owned health institutions in KP to curtail bureaucratic delays and undercut the influence of vested trips. So they work under a board of governors whose members are selected by search and nomination council. MTI Act has allowed them to hire the best people and offer them competitive salaries, which has discouraged private practice. They can hire and fire people based on their performance and purchase the required machinery and other items as and when needed. So this MTI is now being promoted and recently started in PIMS Hospital, Islamabad also. Moving on to certain BHU level of facility reforms. So the Punjab Rural Support Program was given a managerial contract by district government to manage all the BHUs with encouraging results. These include a patient turnover increase by threefold, the supply of drugs has been ensured, the physical conditions of BHU has been improved owing to these reforms. Moving on to the next hospital reform, decentralization. It is the transfer of formal responsibility and power to make decisions regarding the management, production, distribution, financing of health services to geographically and organizationally separate actors. Decentralization in healthcare refers to a system in which most decisions in healthcare are handled by lower levels in the government. Instead of the federal government making all healthcare decisions, local government will make healthcare decisions for the people in their immediate areas. So there are 4 different types of decentralization: deconcentration, devolution, delegation, and autonomization, which is also known as privatization. Deconcentration is passing some administrative authority from central government offices to the local offices of central government ministries. Devolution is passing accountability and a degree of independence to a regional or a local area with or without financial responsibility, that is the ability to raise and spend revenues. However, in delegation, passing responsibilities to local offices or organizations outside the structure of central government, such as arms length bodies, but with central government retaining indirect control. In autonomization or privatization, transfer government functions to independent organizations in the public or private sectors. Privatization, shifting responsibility from government to private sector. There are certain benefits and limitations to this. Benefits include improved allocative and technical efficiency, organizational innovation to meet local needs of a hospital, improved service quality, as well as greater equity together with transparency, accountability, and legitimacy for the health sector. Cost containment, more community involvement, more integration of public and private activities, and intersectoral coordination. And moving on to limitations, these include this need empowered and informed community, active community citizen boards, and village health committees. So it also needs a capacity building and governance and strong management, need effective state capacity for coordination and regulation of governance, legal institutional regulatory framework, and a conflict can arise between individuals of the dominant group. Moving on to a management structure of a hospital, organizations, they may be structured using one of these 5 designs: hierarchical, flat, functional, divisional, or matrix. In case of hospitals, large hospitals and healthcare system, they use a hierarchical design, which is characterized by a clear hierarchy with multiple levels of management. So this is one of the a hierarchical organization of healthcare system or a hospital, which shows the Minister of Health as authority, Secretary for Health working under the supervision of Minister, and under the supervision of Secretary, the medical schools attached with tertiary care, Director General of Health, development programs, and statutory bodies come. After that, the EDO is there, and under this EDO, there is Deputy District Health Officer and District Population Planning Officer. So Deputy District Health Officer also supervises the primary healthcare network. And this is the picture of Mayo Hospital, the hierarchical system of Mayo Hospital, which is present. Moving on to the next reform, that is patient cost sharing. So the scope and depth of services that are covered in any health insurance scheme, they can have a tremendous impact on how much healthcare people obtain, on the cost to the system, and ultimately on the health of the nation's people. So to provide a community with an optimal level of care at a reasonable cost, policymakers at all levels have been rethinking traditional approaches to benefit design and consider the merits of using explicit scientific criteria for more clearly defining the benefit structure. So patient cost sharing include deductibles, co-payments, and co-insurance. In Pakistan, this patient cost sharing, it has a perfect example. Recently introduced Universal Health Coverage Initiative, the Sehat Sahulat program. It can be considered one of the biggest achievements of country's healthcare system. Moving on to the incentivization of the healthcare workers. Incentives for healthcare employees, they are vital tools that go beyond mere rewards. So they embody a healthcare organization's acknowledgement of dedication and sacrifices made by its workforce. Effective incentive programs, they are carefully tailored to meet the diverse needs of various roles within the healthcare sector, from frontline medical staff to support and administrative personnel of any hospital. These programs, they combine extrinsic rewards like bonuses and paid time off with intrinsic motivators such as professional development opportunities, ensuring a holistic approach to healthcare employee engagement and satisfaction. So what are the types of incentives that are included? Number 1 is financial, number 2 is material, number 3 is professional or educational, number 4 is social or recreational, and number 5 is familial. There are certain challenges in improvising these, implementing these reforms in a hospital. Poor performance of hospitals has also always been attributed to several factors, like there is a problem with the paucity of resources and problems with service delivery. The problems with paucity of resources, number 1 is limited management expertise due to the lack of training in this field. And number 2 is lack of opportunities for staff training. Number 3 is absence of formal management and HR tools. And number 4 is misunderstanding, miscommunication between administrators and clinicians. Problems with service delivery include poor attitude towards patients and low standards of care. They arise mainly because of failure to introduce a culture of patient-centered healthcare. And number 2 is most hospitals in the country continue to be overburdened, catering to the needs that can be met at a basic level. So owing to these problems, the hospital reforms, they must be implicated in a hospital for the better and efficient work. Now, what are the solutions to these challenges? Number 1 is training of management professionals. So the recent introduction of this as a specific area for postgraduate training by CPSP is an important step. Introducing a culture of patient-centered care can also be addressed through better management. Provide managerial autonomy to institutions. Hospital autonomy empowers the administration, both at the managerial and financial levels. Hospital restructuring for alternative modes of financing. They can reduce dependency on government subsidies to make hospitals sustainable and efficient while still providing for poor. This can be best achieved by providing financial autonomy to hospitals. Basic healthcare facility reforms. So reaching out to services like NGOs, individual healthcare providers, entrepreneurs, with or without providing subsidies on a sliding scale for some years. Developing community co-management packages, developing management of these facilities to lower the levels of government, maximizing efficiency within the existing system by making them administratively and financially autonomous. So these are the solutions to the challenges faced by hospitals. Now, moving on to the certain recent advances. This is the article that was published in 2024. This shows decentralization of the health system experiences from Pakistan, Portugal, and Brazil. According to this research, this paper aims to provide a comprehensive description of decentralization process in 3 countries at different stages of their decentralization strategies, like Pakistan, Brazil, and Portugal. Comparing our 3 countries, it was evident that all 3 have prioritized health in their decentralizing reforms and aim to enhance local decision-making. Brazil has made significant progress in implementing decentralization reforms, while Portugal and Pakistan are still in the process. Pakistan has faced significant implementation challenges, including capacity building, resource allocation, resistance to change, and inequity to access to care. Brazil and Portugal have also faced challenges, but to a lesser extent. So, conclusion is that it is important for Portugal, Brazil, and Pakistan to address these through reinforcing implementation strategies, tackling inequalities in access to care, and enhancing monitoring and evaluation mechanisms. Additionally, fostering knowledge sharing among these different countries will be instrumental in facilitating mutual learning. There is another article published in June 2022, Autonomy of Public Hospitals in Pakistan in the Time of COVID-19. It is a policy perspective. Governments, they usually introduce management reforms to restructure their institutions. In the later decades of the 20th century, the developing countries initiated hospital autonomy reforms to increase healthcare service quality and resolve healthcare financing. Therefore, Pakistan initiated the policy of hospital autonomy in 1993 and implemented a pilot project in 1999 with the financial and technical support of the World Bank. The policy's objective was to increase the quality and quantity of healthcare services without any considerable fiscal increase. COVID-19 has emerged as a vital issue that needs the immediate attention. So it has affected the vital domains of healthcare, including hospital autonomy. Exploratory interviews with experts, including the hospital managers and bureaucrats, were conducted under the snowball sampling technique. We also collected a comprehensive set of policy documents to perform document analysis. After approximately 3 decades of policy initiation, the government of Pakistan is still struggling to implement the policy on provisional grounds. So the policy is still not implemented completely. Over time, the amendments in hospital autonomy policy replaced the hierarchy type of mechanism with a market type mechanism. So the scenario contributed to a decrease in the real sense of autonomy. There is no specific monitoring body for this policy that resulted in the delay in its implementation. Now, moving on to the MCQ section. Number 1, a regional hospital is facing criticism for long wait times and outdated facilities. To address these issues, the administration is planning a series of reforms, including the implementation of electronic health records, hiring additional staff, and improving patient care protocols. Which of the following best describes the primary goal of these hospital reforms? A, to increase hospital revenue by expanding services. B, to enhance patient care and operational efficiency. C, to comply with government regulations only. D, to reduce the hospital's expenses regardless of patient outcomes. E, to maintain the current practices to avoid staff resistance.
Answer is C.
The correct answer is B, to enhance patient care and operational efficiency. Number 2, the managerial team at City Hospital is tasked with improving overall patient satisfaction scores, which have recently declined. So the team holds a series of meetings to identify the root causes, gathers feedback from staff and patients, and develops a plan to enhance communication between departments, streamline patient check-in processes, and provide additional training for frontline staff. So the question is, what is the primary role of the managerial staff in this scenario? A, to implement changes without consulting the healthcare providers. B, to prioritize budget cuts to reduce operational costs. C, to engage with staff and patients to identify and address issues. D, to maintain the existing procedures and avoid any major changes. E, to focus solely on financial problems without considering patient care.
Answer is C.
Yes, the answer is C. 3. In a healthcare system, patient cost sharing refers to the out-of-pocket expenses that patients are responsible for when they receive medical services. This can include deductibles, co-payments, and co-insurance. Which of the following statement best describes the purpose of patient cost sharing? A, to eliminate the need for health insurance coverage. B, to encourage patients to seek more expensive treatments. C, to reduce overall healthcare costs by sharing expenses between patients and insurances. D, to ensure that only high-income individuals can afford healthcare services. And E, to shift all financial responsibility to the healthcare providers. Okay, so the correct answer is C. Number 4, a regional healthcare authority is considering decentralizing its hospital services to improve efficiency and responsiveness to a local community needs. Currently, decisions regarding staffing, budgeting, and patient care policies are made of a central office. The proposed changes would empower individual hospitals to manage their resources, adapt services based on local demographics, and foster stronger community engagement. What is one potential benefit of decentralizing hospital services as described in the scenario? A, increased uniformity in care across all hospitals, regardless of local needs. B, enhanced ability for local hospitals to tailor services to the specific needs of their communities. C, greater oversight and control from the central authority over every operational decision. D, reduced administrative costs by eliminating local management positions. And E, a one-size-fits-all approach to healthcare that minimizes local input. Okay, so the correct option is B, enhanced ability for local hospitals to tailor services to specific needs of their communities. 5, a hospital board is discussing the importance of granting managerial autonomy to its administrative team. This autonomy allows the management to make decisions regarding staffing, budgeting, and patient care without needing constant approval from the board. Which of the following is a potential advantage of increased managerial autonomy in hospitals? A, it may lead to inconsistent patient care across different departments. B, it can facilitate quicker decision-making and responsiveness to patient needs. C, it diminishes accountability by shifting responsibility away from the board. D, it creates a reliance on external consultants for decision-making. E, it restricts innovation by adhering strictly to established protocols. Correct option is B. It can facilitate quicker decision-making and responsiveness to patient needs. A hospital is granted financial autonomy, allowing it to manage its own budget, make investment decisions, and set pricing for services independently from a central authority. What is the one significant benefit of this financial autonomy for the hospital? So increased bureaucratic oversight in financial decision-making. B is greater flexibility to allocate resources based on patient needs and priorities. C, a guaranteed increase in funding from government services. D, reduced responsibility for financial performance and accountability. And E, standardized pricing that limits the hospital's ability to compete. So the correct option is B, greater flexibility to allocate resources based on patients' needs and priorities. 7, Mayo Hospital is undergoing a major reform initiative to improve patient care. The management has introduced new protocols, upgraded technology, and reorganized staff roles. However, several weeks into the implementation, they noticed that many staff members are hesitant to adopt the changes. Some expressed concerns about the new technology. So what is the primary challenge the hospital is facing in the application of its reforms? A, high level of community support for its changes. B, clear and effective communication from management about the reforms. C, resistance from staff due to uncertainty and the fear of change. D, an abundance of resources available for training and support. E, a rapid improvement in patients' outcomes since the reforms began. So the correct option is C, resistance from staff due to uncertainty and fear of change. 8, a public hospital has implemented an educational incentivization program to encourage its staff to pursue further education and training. Under this program, employees who complete a relevant certificate will receive financial bonuses. So the administration hopes this will enhance the skills of the workforce and improve patient care. However, some staff members are concerned about the time commitment required to pursue additional education. What is a potential challenge that this hospital may face with this educational incentivization program? A, increased motivation among all staff to pursue education. Enhanced collaboration and knowledge sharing among employees. C, resistance from staff who feel overwhelmed by the additional workload. D, improvement in patient care due to a more skilled workforce. E, is the greater retention of staff due to career advancement opportunities. So the correct option is C, resistance from staff who feel overwhelmed by the additional workload. 9, at City Hospital, the management structure follows a strict hierarchical model with clear levels of authority, as the CEO sets policies that are communicated down the layers of management to department heads, who then relay them to staff. Recently, some nurses have experienced frustration over the slow response to their suggestion for improving potential patient care, citing that their input often takes too long to reach decision makers. What is the potential drawback of the hierarchical management structure of City Hospital as described in scenario? A, it encourages open communication and quick decision making. B, it can lead to delays in implementing changes based on frontline feedback. C, it allows for rapid sharing of ideas between all levels of staff. D, it fosters a collaborative environment among departments. And E, it ensures that all the staff members have equal say in decision making. So the correct option is B, it can lead to delays in implementing changes based on frontline feedback. 10, the board of a medical center has decided to pursue greater autonomy for the hospital to improve operational efficiency and patient care. To implement this change, they plan to take several steps, including redefining the governance structure, empowering management to make decisions as part of this initiative. They also aim to engage staff at all levels to ensure a smooth transition. What is one critical step that this medical center should prioritize to successfully institutionalize hospital autonomy? A, limiting staff input in decision-making processes to streamline approvals. B, increasing central oversight to maintain strict control over hospital operations. C, developing clear guidelines and training programs to empower staff at all levels. D, reducing the budget for staff development to allocate funds elsewhere. E, maintaining existing hierarchical structures to avoid confusion during the transition. So the correct option is C, developing clear guidelines and training programs to empower staff at all levels. That's the key to the MCQs. That is the link of our YouTube channel where the presentation will be uploaded. Please like, subscribe, and share. And thank you.